Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Lung Cancer Update 2023. With immense pleasure, I would like to invite Dr. Shiv Shankar, who is Consultant Medical Oncology at prestigious Rajiv Gandhi Cancer Research Institute, Delhi, for the welcome and introductory note and to take the proceeding further. Thank you, sir. Welcome to you. Over to you, sir.
Good evening, everyone. We all know that lung cancer is one of the common malignancy across the globe as well as in India too. It's among the 5 leading causes of cancer, and also it tops in the mortality due to cancer. And also we have seen that in last decade, there is a rapid change, landmark change in the management of lung cancer, be it non-small cell lung cancer or small cell lung cancer. There is a dramatic improvement as well with this change in treatment. The outlook of, if I take an example of all positive lung cancer, which was roughly to the tune of 1 year or 1.5 year, 5 year survival in a metastatic all positive, now it has crossed beyond 5 years. So there are a lot of changes happening every year, new drugs keep coming. So it becomes a necessity to get updated with the changing management so that we can choose wisely when we manage our lung cancer patients. So with this thing in my mind, we have organized this lung cancer update to look at what has recently been some changes which has happened. I understand that within this short duration of 2 hours, we cannot cover in totality about of all the things which have changed in lung cancer, but we'll try to touch upon some of the important topics that are happening in lung cancer domain. At the outset, I also would like to thank our sponsors, AstraZeneca, Roche, and Intas for providing this wonderful opportunity to discuss these important changes which are happening in lung cancer domain. So without wasting much of time, I'd like to kickstart today's session. I hope Dr. Dubey sir has joined.
Yes, sir. He's connecting. I think he's there.
So first we will have our first talk, our opener will be Dr. Dubey sir. He is a star performer. We all know that he does not require any introduction. And the topic is immune checkpoint inhibitor in small cell lung cancer. We know that in last 20 to 25 years, chemotherapy alone, that is doublet chemotherapy, platinum plus etoposide was the standard of care. However, in last 4 to 5 years, we have seen newer drugs coming in, even in the management of small cell lung cancer. And we have immunotherapy options also in small lung cancer. So Dr. Dubey will talk about what are the immune therapy options in small cell lung cancer and how it has changed the management. I'd like to invite Dr. Dubey sir to give his talk.
So thank you, Shiva, and thank you, Rosh, for giving me this opportunity. I'm so sorry that I joined late because there was some Wi-Fi problem. So as Shiva has already told that I will discuss about the role of immune checkpoint inhibitors in small cell lung cancer. So why this is not moving? Okay, so this is my disclaimer slide. Sorry. I guess I have already shared my screen.
Dr. Dubey, we are presenting slides from our side. Please just say next when you want us to change slides.
Madam, let me share the screen. I can share
it.
Sir.
Okay.
So that's why I was not able to move it. Okay. So these are the table of contents under the subheadings I'll be discussing in next 20 or 25 minutes. So as we all know that lung cancer is the most commonly diagnosed malignancy among males, and they account for around 11 to 13% of all newly diagnosed malignancy. And non-small cell lung cancer account for the majority of the chunk, that is 85%. But there's
sorry to interrupt. Your slides are not yet shared, sir.
Not yet shared. One second. One second. Is it clear now?
Yes, sir. Yes, sir.
Just make it in presentation mode.
Okay. So as I was saying that lung cancer is most commonly diagnosed malignancy among males and accounts for around 11 to 13% of all newly diagnosed malignancy, where non-small cell lung cancer accounts for the majority of the chunk, around 85%. But there's also one entity, that is small cell lung cancer, which accounts for around 15 to 20% of all lung cancers. They are quite different from non-small cell lung cancer, as they are very fast growing. They are actually aggressive tumors with high mitotic rate, and which are highly chemosensitive as well as radio sensitive. But the median overall survival is quite dismal, despite whatever treatment modalities we had till around 5 years back. These tumors are very much prone for very early metastasis and tend to be presenting at an extensive stage. Although the median age is 65 years, but in our country, almost the individuals at the age of 40 to 50 years are actually presenting with this small cell lung cancer. Most of the patients are smokers. Only rarity of the patients you'll find in small cell lung cancer who are never smokers. In contrast to non-small cell lung cancer, where we have many driver mutations have been evolved and we have many targeted therapy, but in small cell lung cancer, we have actually lacuna of these studies as well as therapies. So that's why the median overall survival in these patients remains dismal, and leading to an unmet need of some effective therapy to give them a maximal benefit to the patients. As I was saying, that these are very aggressive tumors, and the 5-year survival rate is around 2%, whereas in non-small cell lung cancer, it has almost reached 20-25%. Here it is only 2%. And there are multiple small cell lung cancer subtypes, but the most common is small cell carcinoma. So small cell carcinoma, or which you can also say that neuroendocrine. The staging in small cell lung cancer is also different. The most commonly used staging is what you can see in the slide. That is either a limited stage. Limited stage means the total disease burden can be encompassed in a single radiation field, whereas extensive stage, when the disease burden or the total disease cannot be encompassed in one radiation field. So that extensive stage also, we can say it in a layman language, a metastatic disease. So these patients, actually, the patient with small cell lung cancer, around 65 to 70% of the patient actually present with the extensive stage. Extensive stage means the disease where our intent will not remain curative because they cannot be encompassed in a single radiation field. So we will not be able to give that concurrent chemo-RT, which remains a curative modality in these patients, although the recurrence rates are very high. So around 65 to 70% of the patient will present with the extensive stage, where only 30 to 35% of the patient will present with the limited stage of the disease. But in our country, the disease, the status is more worse. That is around 75%, means 3/4 of the patients are presenting with the extensive stage disease, and only 1/4 of the patients are presenting with the limited stage disease. What are the treatment modalities we have? Surgery, in contrast to non-small cell lung cancer, here it does not play that major role. Only in very few patients the surgery can be given as an option, because these patients are these tumors are very aggressive and generally present with an advanced disease. So what we have in the limited stage disease, that is chemo-RT, and in extensive stage disease, the systemic therapy and the prophylactic cranial irradiation. So this is the treatment landscape in patients of small cell lung cancer treatment. So as we see that we have many chemotherapy drugs coming up in last few years, but the FDA has approved etoposide plus platinum-based combination as the standard of care, And you'll not believe that in last 2 decades, no new drug was been added in this treatment landscape until unless 2018, that is just 5 years back, when the immunotherapy was being introduced into this treatment landscape. So the treatment scenario in India also remains the same, that the systemic disease is generally treated with combined modality approach of radiochemotherapy if it is limited stage, and cisplatin plus etoposide remains the standard first-line therapy in small cell lung cancer if it is an extensive stage. And patients will actually receive platinum etoposide doublet as first line, that is 70%. But as per me, my colleagues will also agree that around more than 85 to 90% actually receive the platinum etoposide doublet. So despite this platinum etoposide doublet, the 5-year overall survival rates are quite dismal. That's around, there was a significant, or you can say there's an unmet need of an effective therapy which can actually prolong the survival rate in these patients. You can see that from last 2 decades, difference in the overall survival which has changed was only around 2.5%. In Indian scenario, you can see that the patient's 5-year survival rate is 2.5%, whereas 2-year survival rate is 5.9%. These patients are quite radiosensitive and chemosensitive, and with the overall response rates going to around 90%. But still, despite being such chemosensitive and radiosensitive disease, the median progression-free survival and the median overall survival remains quite low, with the 5-year overall survival is around 2%. In the year 1990s, the FDA has approved carboplatin and etoposide as the first line or the standard of care for extensive stage small cell lung cancer. As I've said, that surprisingly, that for the last 2 decades, no other drug has been approved in this treatment landscape until the year 2018, when immunotherapy or immune checkpoint inhibitors were introduced into the landscape, and they have actually significantly improved the survival in these patients. So what is the rationale behind chemoimmunotherapy? Or because now the standard of care remains immune checkpoint inhibitor, that is atezo plus platinum etoposide combination. Why it is so? Because when we give chemo, there's a killing of tumor cells, and those so many tumor antigens will be released, and such tumor antigens will actually enhance, or they will activate the immune system. That immune system, which was under immune surveillance because of release of certain molecules by the tumor, that is PD-L1, the PD-1 and PD-L1 interaction, which has resulted in down gradation of T cells, is actually inhibited by anti-PD-1 or anti-PD-L1 antibodies, and that result in revoking or activating the suppressed T cells to kill cancer cells. So combination chemoimmunotherapy with chemotherapy have been actually successful in extending the survival in non-small cell as well as small cell lung cancer. So this is rationale for IMPAR 133. So why IMPAR 133 and why we need immune checkpoint inhibitor? That's very clear, because the overall survival remains dismal. There were no new drugs being introduced, and all the chemotherapy, whatever new chemotherapies were introduced, they were not being able to significantly improve the survival outcomes. The goal of chemoimmunotherapy combination is to create more favorable environment to maximize the potential of the immune system to eliminate the cancer from the body. This is the trial schema, the randomized phase 3 study, where extensive stage small cell lung cancer, where patients were chemotherapy naive with ECOG PS 0 to 1, were randomized to atezo plus carbo plus etoposide vis-a-vis placebo plus carbo plus etoposide, and patients who have responded in the term of CRP or a stable disease were given maintenance, either atezo or placebo, till progressive disease. The co-primary endpoints were progression-free survival and overall survival. PCI was permitted in IMPAR 133 because in clinical practice also it has shown improvement in the survival outcomes. Whereas consolidated thoracic radiotherapy was not permitted because there are contradictory trials not showing benefit of thoracic radiotherapy, but that can be tried on an individual basis in patients who have the majority of disease in the thorax and very low bulk of extrathoracic disease. So why only 4 cycles were given in IMPAR 133? Because there are studies where it has shown that more than 4 cycles, if we increase the number of cycles, there were no clear significant clinical benefit was achieved. And why the only carboplatin was used, although the cisplatin has shown improvement in response rate as well as survival, non-significant survival outcome in patients with non-small cell lung cancer. But here is a meta-analysis in small cell lung cancer that cisplatin and carboplatin have comparable efficacy in first-line small cell lung cancer. And also, although cisplatin has more response rate, but here our intent remains palliative, to prolong the life and to maintain the quality of life. Cisplatin is associated with quite toxic safety profile, which is not in the case of carboplatin. It has lower renal, neurological or GI toxicity than cisplatin. Only hematological toxicity is the problem that can be tackled. So the primary and secondary endpoint, as I've said, that OS and PFS, where secondary was ORR and duration of response and safety. These are the baseline characteristics. You can see the baseline characteristics were actually were balanced between the 2 arms. And this was the first primary endpoint, that is overall survival. You can see that overall survival was significantly increased with the addition of the immunotherapy, that is Atezo. The median OS was 12.3, and at 12-month OS was 51.7% versus 38.2% in the placebo arm, with a hazard ratio of 0.70 on the median follow-up of 13.9 months. And also at the 1.5 years, means 1.5 years, 18 months overall survival was 34% with the immuno plus carbo-ito, whereas only 21% with the placebo plus carbo-ito. So 3 times patients, as many ongoing responses with Tecentriq plus etopo carboplatin. The second primary endpoint was investigator-assessed progression-free survival. You can see that median PFS was 5.2 versus 4.3 months, with a hazard ratio of 0.77, with the median follow-up of 13.9 months. You can see that 6-month PFS is 30.9%, with a 22.5, and 12-month PFS is more than double, 5.4% versus 12.6 with Atezo arm. The confirmed overall response or objective response rate were actually similar, and the median duration of responses were actually numerically higher with the Atezo arm, and 6 months event-free rates and the 12 months event-free rates were higher with the Atezo arm, and patients with ongoing responses were quite significantly higher in the Atezo arm as compared to the placebo arm. Now this is the forest plot. You can hardly see any subset which is not attaining the benefit with Atezo plus chemo, irrespective of sex, age, ECOG PS, metastasis, and blood tumor mutation burden. So all except for one odd subset are achieving the benefit. So this is the summary of the trial, that Atezo plus carboplatin plus etoposide. That is 4 doses of carboplatin, because 4 cycles, 12 doses of etoposide. Here the treatment-related adverse events were almost similar. Treatment-related serious adverse events, you can see almost similar, 35.2 with placebo arm and 38.9 in Atezo arm. And adverse event leading to withdrawal from Atezo were 11.6%. So this is the summary. 4 cycles of Atezo plus carboplatin plus etoposide followed by Atezo maintenance, whereas either placebo plus carboplatin plus etoposide followed by placebo maintenance. PFS is significantly improved. Overall survival is significantly improved, and 12-month overall survival is significantly improved. That is, the difference is 13.5%. So even the treatment guidelines, what they say, let's see. That all extensive stage small cell lung cancer, if they have poor PS, then systemic therapy should be given, including the systemic supportive care, plus minus radiotherapy if the patient is eligible for that or able to tolerate that. And if the poor PS is not due to small cell lung cancer, not due to the disease itself, Then we have to individualize the therapy, and the supportive care remains the backbone. Where the patient with brain metastasis, if asymptomatic, then we should go ahead with the systemic therapy, followed by the whole brain radiotherapy. Whereas if it is symptomatic, then initially we should involve the patient into whole brain radiotherapy, followed by the systemic therapy. So this is the summary of trial. The first positive trial of immunotherapy plus chemotherapy combination for first-line extensive stage small cell lung cancer. This was a major milestone achieved in the 20 years because no drugs were approved, no new drugs were approved or introduced in the treatment landscape of small cell lung cancer, which have shown the clinically meaningful improvement. But here the atezo plus chemotherapy has shown significant and meaningful improvement in overall survival as well as progression-free survival as the current standard of care in first-line extensive stage small cell lung cancer when compared to the placebo arm. Also, atezo plus carbohydrate combination is recommended by all the standard guidelines, including NCCN and ESMO, and all other treatment guidelines for the upfront treatment of patients with extensive stage small cell lung cancer. Now, if you see the survival benefits demonstrated in IMPAR 133, median overall survival was 12.3 months versus 10.3 months. Patients who were alive at 1 year were 52% with atezo, where 38% with placebo. And IMPAR is also investigating the combination of atezo with chemotherapy in all comer population, regardless of biomarker status. So, I guess I was able to give the justice to this new drug, which was being approved just 4 to 5 years back and significantly improved the outcomes in patients with a very deadly disease, that is small cell lung cancer. So, thank you. Thanks a lot.
Thank you, Dubey sir. It was definitely an excellent oration, and it was a comprehensive overview. You also touched upon very nicely about even the biology of disease as well as the recent changes in the management of small cell lung cancer. I have 2 questions. One is, do you choose any biomarkers like in non-small cell lung cancer or any in other cancers for choosing immunotherapy in small cell lung cancer? Do you choose up any biomarker or any other criteria to use IO apart from fitness and cost? And second question is your experience with atezolizumab.
Okay.
Small or non-small cell lung cancer.
Okay. So, like first question, in non-small cell lung cancer, surely I go ahead with the PDL1 / TPS score, depending upon what molecule I'll be offering to the patient. But in small cell lung cancer, this I'm not doing because the outcomes have shown that irrespective of the PDL1 status, these patients have achieved the benefit. So as of now, maybe the further results will come and we might be using these markers in those patients also, but I am not using these markers in patients with small cell lung cancer. And second, about atezo, I have used atezo both in non-small cell lung cancer and small cell lung cancer. And non-small cell lung cancer, I have presently 3 patients who have been treated on the basis of IMPAR 150, that is atezo plus chemo plus bev. So there are 3 patients who are presently undergoing that treatment. And just I want to say that even that there was a chatter about that particular combination therapy might not be tolerated, but all my patients are actually tolerating that patient. And then one patient I have, like the first cycle I was about to give today. In small cell lung cancer, yes, that is a deadly disease. Patients have responded, but those responses have not been were durable. And maybe we might require certain more biomarkers, certain studies, which will help us to become more intelligent in particular this field of disease to give the maximal benefit that how to choose immunotherapy in this set of patients. Thank you.
Thank you, sir, for those clarifications. As sir has clearly mentioned that as of now in small cell histology, we do not have much of a scope to choose any particular patients. in both the studies, it was shown that irrespective of PD-L1 status or TMB status, patient do similarly, whether it is high TMB, low TMB, or high PD-L1 or low PD-L1. Probably, as sir also mentioned, that probably in the coming days, we might see more and more markers to help choose wisely. If there are no further questions, we'll move on to the second topic. I'll invite Dr. Harpit, consultant at Rajiv Gandhi Cancer Institute, Delhi. We know that in non-small cell lung cancer, from the last 1 decade, we are seeing that we are using biomarkers or molecular markers to choose treatment options, particularly in metastatic setting. Nowadays, even in the early stage lung cancer also, we are using molecular markers. Early days, we used to do in a particular scenario, like somebody who is non-smoker, who is adenocarcinoma, female patients. Only in those patients, we used to do molecular profiling. However, in the last few years, it has changed. And not only few markers, now array of markers have come up. And Dr. Harpit will touch upon how do we sequence, how do we do this molecular profiling in non-small cell lung cancer. I do invite Dr. Harpit Jain to take over.
Good evening. Thank you, Dr. Shiva sir. Thank you for the organizers. My job is to discuss the various biomarker testing in particularly non-small cell lung cancer patients. Just a minute. Okay. The whole scenario of my talk will be, I will discuss about the profile of the lung cancer in the Indian patients. Then I will discuss the various biomarker tools for testing the mutational analysis. Then I will discuss the evolution of these biomarker tests and their role in the past and what all biomarkers are there in the current scenario. Then the final key takeaways will be disclosed. So as per the Globocon 2020 data, in Indian settings, lung is the 4th most common cancer in the newly diagnosed patients in all the ages in both the sexes, while it is 2nd most common cancer in the males. And amongst all the non-squamous NSCLC patients, about 50% of the patients have any type of driver mutation which can be targetable. So most common targetable mutation is basically KRAS G12C mutation. Then the other one is EGFR mutation, then the ALK, ROS1, and so on. So we have a whole array of these mutational profile. So what is the importance of basically doing this biomarker testing in the non-small cell patients? So these curves are showing that amongst the patients who have been diagnosed with a particular driver mutation, if we treat them with a targeted therapy, or if we do not offer any targeted therapy, or we directly treat them with the chemotherapy, there is a drastic improvement in the median overall survival. So if we offer a particular targeted therapy, then the median OS is 18.6 in compared to only 11.4 months. So basically, this is the basic difference between treating the patient with the targeted therapy or not. So various guidelines has recommended, basically all the guidelines recommended at least 3 mutational analysis upfront in the advanced NSCLC patient, which is EGFR, ALK, ROS. NCCN has recommended an array of 8 mutational analysis, which is EGFR, ALK, ROS1, BRAF, MET exon 14 skipping mutation, RET gene fusion, and so on. So apart from that, PD-L1 expression is being recommended by all these guidelines. So what are the methods of tissue testing in the NSCLC? Most commonly, it is IHC and FISH, which is cost effective and very short turnaround time. But the sensitivity is again an issue. So with ALK and ROS1, FISH is better. And again, IHC can be done for ALK and ROS1. Similarly, for testing the fusion abnormalities, particularly like ALK fusion, ROS1, RET and NTRK fusion, RNA-based NGS panels have more sensitivity in compared to the DNA-based NGS. Similarly, DNA-based sequencing are more commonly detects the insertions, point mutations, and the deletions. So what are the evolution of the biomarker testing? So basically, since the beginning of the acquiring the tissues, firstly, they do a morphological examination. Then after finalizing the diagnosis, whether it's a small cell or the non-small cell, reflexively, we do a IHC testing to segregate between the adenocarcinoma or the squamous cell carcinoma. And depending upon the molecular profile, we do a certain test. So usually we start from the EGFR, which is the most common mutational in Asian population particularly. And then subsequently we offer a ALK ROS1. And if everything goes negative, we do a NGS. So biopsy, basically to stabilize the diagnosis again. And then we subsequently send the tissue to the molecular lab for the biomarker testing. So we usually do as per the NCCN guideline, at least for 8 mutational analysis, we usually offer. So test for the EGFR, ALK, ROS1, BRAF V600E, NTRK fusion, RET fusion, and MET exon 14 skipping in all the non-squamous NSCLC patient. Apart from that, test for the PD-L1 testing is also offered upfront. So basically, the recommended time for the turnaround time for these biomarker testing should be 10 to 14 days. So what is the role of the ctDNA testing basically? So as we all know that in NSCLC patients, tissue is a big issue. So ctDNA has a particular role starting from the diagnosis to the monitoring of the response to the treatment. Then we can also offer as a MRD testing also. Then we can also do a ctDNA testing for assessing the progression or then subsequently relapse. So ctDNA testing overcomes certain major challenges which we cannot target in the tissue-based sampling also. So basically the tumor heterogeneity is an advantage. So down the course of the journey of the treatment, as the tumor profile changes, so we can address it by the ctDNA testing early. Similarly, so there was a Tracer X study where 24 early stage NSCLC patients were followed longitudinally after the resection of the primary tumor. They found that 93% of the patients with disease recurrence were MRD positive. So they sequentially assessed the ctDNA analysis, and they found that 9 out of the 10 patients who did not recur, they were also MRD negative. So this ctDNA was actually have a very good concordance. Similarly, this chart is showing that what is the actual difference between the tumor tissue versus liquid biopsy based testing. So basically, sample acquisition is a problem. It is an invasive procedure to obtain a tumor tissue. Sometimes patient profile do not permits the biopsy. If the patient land up into the MICU, and it is very difficult to plan a biopsy and all. So there is a particular role of the liquid biopsy. Again, repeat sampling is an issue, and the amount of the tissue is again an issue. Since these tumor, basically getting a biopsy from these lung tissues is very difficult. So requires a very expertise actually. And again, the sensitivity is very high of the liquid biopsy. It is to the tune of less than 0.1% for getting a cfDNA positivity. So there is a multiple genes involved in the NSCLC. So single gene reflex testing is better. So getting it one by one, it is altogether better to get a single time testing. So these are the advantages of the NGS. So if we need to assess a particular molecular markers, so we can go through a stepwise manner. So we can offer a EGFR by RT-PCR, then the ALK by IHC, ROS by FISH, and so on. If everything goes negative, then we can offer a NGS test. So if we require if we need to do a whole array of the molecular testing, so NGS is better in terms of turnaround time, also in the cost. So these are the various techniques which are recommended for testing these particular gene profiles. So to begin with the EGFR mutation in the lung adenocarcinoma. So for testing the EGFR mutation, we can use fresh frozen plasma extract, fresh frozen or the alcohol fixed specimen, basically for the RT-PCR or any like qPCR also. Similarly, cytology samples are also suitable for testing the EGFR mutation testing, and the concordance is particularly very good for doing it either by the primary or the metastatic site. So we can access the tissue either from the primary or the metastatic site. So then there is a trial, ADORA trial, which shows that testing EGFR testing in the early stage NSCLC is offering the treatment based on the EGFR testing in the early has a role. So as per the trials data, NCCN also incorporated the EGFR testing for the early stage, particularly stage 1B to 3A NSCLC patients. So there is an advantage of the NGS over the PCR. One study particularly for the EGF exon 20 insertion mutations. So one study shows that 48% of the EGFR exon 20 insertions identified by NGS are usually missed by PCRs. Similarly, out of 17 most common EGFR exon 20 mutation variants, only 4 can be detected by the PCR. So then comes the ALK rearrangement in the NSCLC. So usually we used to test the ALK by the IHC. It has a very good sensitivity of around 93 to 100%. But there is a issue of the false positivity with the IHC. Again, we can also test the ALK by the FISH. It has a very low false positivity of the 0.1% only. So basically, we can do a test by ALK IHC. In case we can also confirm it by the FISH also. IHC is a less expensive, hence it is more often adopted in the routine practice. Then comes the ROS1 rearrangement in the NSCLC patients. So ROS1, so basically, as I already told, that NSCL in all the NSCLC, basically non-squamous NSCLC patients, we usually do the EGFR, then the ALK, then in reflex we offer the ROS1. So ROS1 requires a double check. So if ROS1 is positive from the IHC, we need to confirm it by the FISH. And again, if it is positive by ROS FISH, then we need to confirm it by the IHC also. Then comes the KRAS mutation testing. So KRAS is the most common type of the mutation in all the lung adenocarcinoma patient, to the tune of 30%. The most common of these is a G12C mutation, which is around 30% of the patient, and we have a targetable drug against this thing also. So the method of the detection is we can do it from the IHC also, but it is not that sensitive. The most sensitive method is multi-gene NGS panel. So we have a sotorasib and the adagrasib against these KRAS G12C mutation positive NSCLC patients. Then comes the testing for the BRAF mutation. So BRAF V600, particularly BRAF could be a V600E mutation or non-V600E mutations. V600E mutation is present in more than 50% of the BRAF mutation patients. Rest in 17% of the patients, other variants could be there. So overall, only 1 to 5% of the patient of the NSCLC patient could have a BRAF mutation. So we used to test it by the multi-gene NGS based panel only. So we have a dabrafenib trametinib based chemotherapy based targetable therapy against the BRAF mutated NSCLC patients. Then comes the c-MET receptor tyrosine kinase and the MET exon 14 skipping mutations. So basically, there are certain introns and the exons. During the transcription phase, if there is any aberrant splicing or particularly exon 14 skipping happens during the transcription phase, then this mutation occurs and it promotes the other downstream pathway activation and further constitutive kinase activation also. So c-Met mutation is actually present in 3 to 4% of the non-small cell, non-squamous, non-small cell lung cancer patient. And it is more often present in sarcomatoid variant of the NSCLC patient to the tune of 20 to 30%. And again, we have a targeted oncogenic drug against c-Met mutation also. Then comes basically for testing the MET exon 14 mutation, IHC and FISH is not recommended. We usually used to do a NGS, particularly RNA-based NGS is more sensitive for the identifying these mutations. Then comes the RET fusion. So most common fusion partner for the RET is KIF5B. KIF5B is the most common fusion partner for the RET fusion. It is present in 1 to 2% of the non-squamous NSCLC patient. We have a targetable drug, which is selpercatinib and pralsetinib against these mutations. And for testing RET fusion, again, RNA-based NGS sampling is more sensitive. So IHC and FISH could have a false negative results. So better to go with the broad-based panel, which is having both DNA and RNA-based testing. Then comes the NTRK fusion testing. Again, as per the dictum, NTRK fusion is more common in rare mutations and less common in the most common mutations, most common cancers. So again, certain solid tumors which is having a more prevalence of the NTRK fusions, we directly go with the FISH RT-PCR or RNA-based sampling. So and other solid malignancies, we perform it by the directly upfront NGS-based panel only. Then for NTRK fusion, again, NGS, particularly RNA NGS, RNA-based NGS panel is more sensitive. Then comes the HER2 mutation in NSCLC patients. HER2 mutation is present in 3 to 5% of the NSCLC adenocarcinoma patient, which is mostly exon 20 in-frame insertions. Again, HER2 mutational patients shows poor prognosis in compared to the other oncogenic driver mutations. It is more commonly present in the never smoker patients, and both HER2 mutation and amplification should be usually identified by NGS DNA panel. So in 2022, there is a whole paradigm for the molecular biomarker testing, which is recommended by most of the international guidelines. And we have a targetable drug against these particular targeted oncogenic mutations. Then the testing of the PDL1 score. So there are various platforms, which is DECO and Ventana, and they have used separate antibody clones. As DECO used 22C3 and 28A, and Ventana uses SP263 and SP142. So as per the blueprint trial, we can do a PDL1 testing by either of these platform except SP142. So for recommending the atezolizumab, we need to particularly do a testing by the Ventana platform and with the SP142 antibody clone only. And again, they have a different scoring system for taking it as a recommendation for the immunotherapy in the NSCLC patients. So this image is showing various positivity of the PDL1 dose. And the other biomarkers for the immunotherapy in the NSCLC is most commonly used in the clinical practice is PDL1. Rare, which is again, it could be TMB, which is not currently recommended for the NSCLC patients. And then MSI status And again, LAG3 is also a biomarker for the efficacy, for predicting the efficacy of the immunotherapy in the NSCLC patients. So to conclude, biomarker testing in non-squamous NSCLC patients has been significantly evolved from single gene testing to the multiplex testing. Sample should contain at least 10% of the tumor content to have a more sensitive results. Ideal turnaround time should be 2 weeks, and the NGS based panel, which could be DNA plus the RNA, which is a high throughput platform, should be used if we required a multi-gene testing upfront. So these are the various oncogenic targets which should be tested, and these are the various testing methodologies which should be preferably used for testing these things. So with this, thank you.
Thank you, Dr. Arpit, for such a crisp and comprehensive overview of array of biomarkers available in non-small cell lung cancer. Dr. Arpit, I have a few questions. Since you have touched upon various platforms to use these to test these biomarkers, so how often do you use a single gene panel or broad gene panel? And second question is, since you also worked upon liquid biopsy, so how do you, if tissue is an issue, and if you go for liquid biopsy in EGFR testing upfront, so what is the sensitivity in our setup, particularly in Indian scenario? And third question is, you said that for PD-L1 testing we have a various platform and we have a various approved IO agents as well. So do you do only one PD-L1 testing, or how do you address that question?
If we do not have a logistic issues, so I would preferably go with the NGS based testing upfront. So basically what we used in the RGCI, there is a separate smart lung panel where we do a EGFR and ALK testing. Then if it goes negative, then by reflex, we do a NGS based testing. So it definitely changes the turnaround time to a 5 to 7 days. So basically most commonly EGFR and ALK are positive. Then we get a report within 5 to 7 days. Then we can start the treatment based on these results. And the second one, regarding that liquid biopsy reports. So again, if it is being basically used in a very selected population. If the patient is land up into the special ICU setup, and if it is very difficult to get a biopsy, so any body fluid can be sent for the liquid based testing. Again, the turnaround time is only 2 to 3 days. So in those patients, we can basically segregates the need of any whether we can offer certain oral tablet or the chemotherapy, which is considered as a more toxic regimens basically. And the thirdly, PD-L1 testing. So in our setting, we directly go with the SP263 platform, and basically as per the blueprint trial, we can offer most of the immunotherapies based on the results of a single SP263 platform only.
Thank you, Arpit. If there are no further questions, we'll move on to the next topic. The next topic is management of all positive non-small cell lung cancer in advanced testing. I'll be presenting this topic. I think my slides are visible and I am audible. At the outset, I'd like to thank Raj for providing this opportunity to touch upon recent advances in the management of all positive advanced non-small cell lung cancer. We all know that non-small cell lung cancer, lung cancer is the second commonly most cancer worldwide, and also it is the leading cause of cancer-related deaths. Roughly around there were 2.2 million new cases per year across the globe and 1.8 million deaths due to lung cancer across the globe. So if you look at the lung cancer is not a single entity. It is broadly divided into non-small cell lung cancer and small cell lung cancer. In non-small cell lung cancer, again, it is further divided based upon histomorphology into adenocarcinoma, which is the most common type. And roughly, it constitutes around 43% of all cancers or 52% of non-small cell lung cancer, and followed by squamous cell carcinoma, non-small cell carcinoma, other specified carcinomas, as well as large cell carcinoma. So if you look at the epidemiology of lung cancer in India, there were roughly around 72,000 new cases in 2020 alone, and roughly around 66,000 patients died due to lung cancer in 2020. It is one of the most common cancer among men, and the new cases among men were roughly around 51,000 in 2020. So moving on to the molecular, in non-small cell lung cancer, basically we divide into onco-addicted or nano-onco-addicted. Dr. Arpit very nicely touched upon these issues and also touched upon the percentages and how do we test. I'll not go in detail about this. These are the various platforms: FISH, IHC, RT-PCR, NGS, which are available. Commonly for all, we use either IHC or if we are going for a broad panel, we'll do by NGS. So if you look at the incidence of all mutations, it is not as common as EGFR mutations. If you see in the Europe, it is roughly around 3.7%, as opposed to 9.5% EGFR mutations in Europe. Whereas in US, the incidence of ALK mutation is roughly around 8% compared to 17% EGFR mutations. In East Asia, the incidence of ALK mutations is 3.4%. However, if we think of India, the percentage varies between roughly around 5 to 7%. We know that is in adenocarcinoma, non-small cell lung cancer, it is not a single entity. It is also a heterogeneous group of diseases. So if we talk about this ALK positive, which constitutes 5% of the disease, they are more commonly seen in never or former smokers. They are more commonly seen in younger patients rather than in older adults, and more commonly seen in females compared to males. And they are mutually exclusive with EGFR and KRAS. If somebody is harboring KRAS mutations or EGFR, less likely to have ALK positive mutations. However, rarely we may come across the tumor which has both EGFR and ALK as well. If you look at what is exactly the genetic problem that is happening in the ALK, it is a chromosomal rearrangement. That's why it is also called as fusion. So that's why it is very well picked up on FISH or NGS based platform. If you look at the incidence, the reports are mostly retrospective analysis. It varies from 2.7% to 13.2% based on different institutional retrospective studies. And on average, we can say that roughly around 7% of patients do have ALK positivity in non-small cell lung cancer patients. So like EGFR positive non-small cell lung cancer, similarly, we have an array of drugs to manage these ALK addicted non-small cell lung cancer patients in metastatic setting. So the drugs available are crizotinib, ceritinib, alectinib, brigatinib, lorlatinib. They have a various outcomes, different toxicity profile, different cost. So it becomes important for us to choose them wisely and sequence them so that we get a maximum benefit to our patients. So the various trials which establish the role of them are Profile 1014, Ascent-4, Alex, Alta, and Crown. For alectinib, we have also other trials like JLX as well as Elysia. We have 3 phase 3 trials which have demonstrated improved outcomes with alectinib. The recommended dose of crizotinib is 250 mg twice daily. For ceritinib, earlier it was 750 mg, but later it came down to 450 mg once daily. For alectinib, it is 600 mg twice daily. For brigatinib, it is 180 mg. For lorlatinib, again, it is 100 mg once daily. So the first trial which has changed the management of all positive advanced non-small cell lung cancer was crizotinib. It was then the standard of care was chemotherapy. So when compared to chemotherapy, we can see this Kaplan-Meier curve. They are well separated quite early in the disease course. From 5 to 6 months, the curve starts separating, and they are separated even at 2 to 3 years. We can see that there is a plateauing of curves, roughly around 30% of patients. So we do see that 1 in 3 or 1 in 4 patients who are treated with crizotinib, they are long-term. They do not have a progression even after 2 to 3 years. If you look at the final overall survival analysis, however, there was not a significant OS benefit when we choose upfront chemotherapy versus crizotinib. It was crossing the line of unity. Hazard ratio was the confidence intervals were between 0.54 to 1.05. This was probably because crossover later, even the patients who took chemotherapy were they also took other ALK inhibitors. So if we come to the safety profile of the crizotinib, the majority of the side effects were vision disorders, GI upset like diarrhea, nausea, edema, vomiting, constipation. If you look at the grade 3, grade 4 reactions, the common were transaminitis, that is elevated liver enzymes, which were seen in roughly around 14%. Otherwise, crizotinib is well tolerated drug. The next drug which got approved was a ceritinib, which was again compared like crizotinib. It was unlike crizotinib, it was compared again against crizotinib. It was compared against chemotherapy again, which was standard of care then. If you look at again compared to chemotherapy, the improvement was dramatic. The curves again started separating quite early in the disease course, that is probably at the first interval assessment, and the curves kept on separating as the time moved on with a hazard ratio of 0.55. So it has further improved if we remember with the crizotinib, it was roughly around 8 versus 11 months. However, in ceritinib, it has PFS was further increased to 16.6 months. So if you look at the safety profile of ceritinib, some of the problem is ceritinib has a multiple drug interaction. That is one thing to remember, because if patient is on multiple other comorbidities, there is a chances of having drug interaction. Apart from that, the most common side effects were diarrhea, nausea, and vomiting, transaminitis. If you look at grade 3, grade 4 incidence of transaminitis were roughly to the tune of 20 to 30%. Other symptoms were like fatigue, abdominal pain, cough, decreased weight. They were also seen, and blood creatinine, increase in blood creatinine. Nausea, diarrhea, GI symptoms were the most common adverse events with ceritinib. If we look at the quality of life, GI toxicity is reported as a worse for ceritinib than chemotherapy. When compared to chemotherapy, the GI toxicity with ceritinib were much more than the chemotherapy. And also another problem with this crizotinib and ceritinib were, we know that in all positive lung cancer, the common primary site of failure is brain, or upfront at baseline, they will have a brain metastasis. So we want a drug which acts in these sanctuary sites as well. But if you look at the pharmacokinetics of these drugs, crizotinib and ceritinib are actively effluxed from the brain, across the blood-brain barrier through PGP and BCRP, that is breast cancer resistant protein, ABCG group of proteins. Both of these the drugs are susceptible to be taken out of taken across through blood-brain barrier using these PGP and BCRP. So their concentration in the cerebrospinal fluid as well as in brain parenchyma will be reduced compared to the systemic circulation. So we cannot expect much of their activity at these sanctuary sites. So the next drug was brigatinib, which was tested in phase 3 trial ALTA-1. In this trial, it was compared to crizotinib, which was then the standard of care. If you look at this trial, further there was improvement compared to brigatinib from 11 months to almost doubling of PFS to 24 months with hazard ratio of 0.49 with a significant p-value of less than 0.0001. If you look at the PFS, the next drug is lorlatinib. Lorlatinib was tested again. It was tested in the later line setting, which has shown significant improvement. Even if they had used various of these drugs, crizotinib, ceritinib, alectinib, it tend to work even after these drugs fails. So it prompted to use what will happen if lorlatinib is used upfront. In the Crown study, when lorlatinib was compared to crizotinib, there was a huge magnitude of benefit compared to crizotinib. The curves are almost, we can see that there is roughly around 45% difference between these two curves. So if we look at the median PFS, it is not at all reached with lorlatinib compared to median PFS of 9.1 months with crizotinib, with a huge hazard ratio that is 0.19, that is 81% reduction in having any progression event. So lorlatinib definitely it has dramatically improved the outcome for these patients if used upfront. But the concern here with the lorlatinib is the safety profile. So since these patients will be on for quite a long time, so how does it affect? So if you look at the safety profile of lorlatinib, some of the common concerning parameters is deranged lipid profile. However, deranged lipid profile can be easily medically managed. Some of the other things are weight gain, edema, peripheral neuropathy, and cognitive effects. Particularly cognitive effects is something to bother upon, is because these patients will fail in brain, often require radiotherapy. So these are something which are concerning to use in an upfront situation. Otherwise, if you look at the efficacy, there is a dramatic improvement. So next drug is alectinib. So to choose among these drugs, so what we will look upon, how selective the drug is, whether it inhibits only ALK or does it have any other targets which may lead to unnecessary side effects, and what is the potency, what are the resistance mutations available, how often it leads to failure, and how does it work in CNS, and how safe is it? So if one drug qualifies all this, that should be chosen over the other drugs. So if you look at alectinib through these lenses, and we have various trials which provided data for alectinib, that is phase 2 trial, that is AF001JP. Then we have a JLX trial and phase 3 trial of ALEX and ALESIA trial. So alectinib has the largest body of evidence with consistent results in 3 phase 3 trials, supporting alectinib as the preferred first-line treatment option for patients with previously untreated advanced ALK positive. So first, ALEX phase 3 trial, in that stage 3, stage 4 advanced non-small cell lung cancer patients were included who are positive on IHC for ALK. They were treatment naive. They were randomized in 1:1 fashion to alectinib 600 mg twice daily, crizotinib 50 mg twice daily. It was continued until progression, toxicity, or withdrawal. Subsequent therapy and they were followed up for the primary endpoint was PFS, and they were stratified based on whether they had a baseline CNS metastasis, whether they were belong to Asia or non-Asian, and based on the performance status. So if you look at, we have a 4 analysis by 29th November 2019, third exploratory analysis has revealed that we had a median follow-up duration of 48 months for alectinib and 23 months for crizotinib. If you look at the baseline characteristics, They are well matched. If you look at the CNS metastasis, roughly around 38% of the patients and 42% of the patients in alectinib had a brain metastasis, as opposed to 62 and 58% without brain metastasis. And roughly around 14% of patients in the crizotinib and 17% of the patients in alectinib had received radiation for brain metastasis at baseline. Otherwise, they were well matched. So to moving up on primary endpoint, that is progression-free survival. So again, in the ALEX trial, there was a significant improvement in median PFS from 10 to 34 months. That is roughly more than 3 times improvement in median PFS. And if you look at a 1 year, 2 year, and 3 year and 4 year event-free survival, almost we can see that after beyond 3 years, there is a plateauing of curve. So at 3 year, roughly around 46% as opposed to 13.5%. Whereas in at 4 years, hardly there were any patients in crizotinib, but roughly around 43%, probably 1 out of 2 patients did not have progression even at 4 years. So if you look at this forest plot, we can clearly see that across all the subgroups, be it they are young or old, whether they are male or female, whether they are Asian or non-Asian, performance status 0, 1 or 2, whether they had a baseline CN metastasis or not, whether they received prior brain radiation or not, it was favoring alectinib. So if you look at how very important thing with ALK positive is how does CNS metastasis will be addressed with any of these ALK inhibitors. If you look at this data, where we had seen that roughly around 40% of the patients had a brain metastasis. If you look at among them, among those who had a pre-existing brain metastasis, the median PFS with alectinib was 25.4 months as opposed to 7.4 months with crizotinib, which was similar to those who did not have brain metastasis. So the magnitude of benefit was almost 4 times even among those who had brain metastasis. So it gives a very good protection even at these sanctuary sites such as brain. So the final PFS event, even among those who had brain metastasis at 4 years, roughly around 38% of the patients who had brain metastasis also, who were considered as a very poor candidates, even among them, 38% did not have any progression even at 4 years. So if we look at the chance of developing a brain metastasis while on alectinib as opposed to crizotinib, roughly over a period of time, 41% of patients by 12 months had developed brain metastasis. They failed at brain, as opposed to only 9.4% patients failing at brain. That is 84% reduction as compared to crizotinib. If you look at the failure rates in the brain, if you look at the objective response rates, they are almost similar. Roughly around 76% objective response rates were there in crizotinib as opposed to 83% in the alectinib. If you look at the duration of response, again, it was 33.1 as opposed to 11.1 months. CNS progression without prior systemic PD was seen in 45% as opposed to 12% in alectinib. Systemic progression without prior CNS PD was seen in 24% in alectinib as opposed to 22% in the crizotinib arm. So if you look at the depth of response with alectinib, roughly around 90% of the patients had a more than 50% reduction in the tumor, as opposed to only 64% who had more than 50% reduction with crizotinib. So the depth of, if we say in like hematology, the depth of tumor reduction, it is huge with alectinib. And those patients who had more than 75% reduction, again, there were 43% as opposed to 25% in the crizotinib. So so what we can expect from this depth of response is probably symptom control will be much more higher in the alectinib as opposed to crizotinib. can be used as a surrogate marker for stroke. If you look at the 5-year overall survival for alectinib, it was not yet reached. Means those who are put on alectinib, they were more than 50% of patients were alive even at 5 years, as opposed to 48 point as opposed to roughly around 48 months with the crizotinib. So among patients receiving alectinib, roughly around 6 out of 10 patients were alive with alectinib. So if you see this at 5 years, only 45% patients were alive on crizotinib, as opposed to 62%, roughly around 17% increase in the number of patients who were alive at 5 years. Safety profile, that is an important question, because previously we had also seen that a significant improvement in outcome with lorlatinib. However, lorlatinib was not easy to tolerate compared to crizotinib. If you look at the alectinib, the side effects were almost better compared to crizotinib. If you look at grade 3 grade adverse events, when we expect that there is increased efficacy, there might be increase in side effect as well. But we see that grade 3, grade 5 were almost similar and numerically lesser compared to crizotinib, as opposed to 56% they were seen in 52% with the alectinib. So if you look at the common side effects with alectinib, again, they were nausea, diarrhea, vomiting. Similar to what we see with the crizotinib. If we see in crizotinib, the incidence of these GI toxicities were to the tune of almost 50%, as compared to oddly in 10 to 15% in the alectinib group. If you look at the transaminitis, again, they were much more lower, 34% versus 18%. If you look at the visual impairment, which is common with crizotinib, is oddly seen in alectinib, as opposed to 12%, it is only 2%. Rashes were almost similar to crizotinib, though numerically higher in the alectinib. And even neurocognitive effects were oddly seen in alectinib, and it seemed to be a safe drug similar to crizotinib. So what does guidelines do recommend? Definitely NCCN in 2023 recommends all these brigatinib, lorlatinib, alectinib as the category 1 recommendation, ceritinib as other recommended. Among them, the preferred are alectinib. So similarly, ESMO guidelines also recommends that the preferred drugs are alectinib, brigatinib, lorlatinib, crizotinib, ceritinib as their first. They are all the option in the first line setting in the management of all positive lung cancer. So apart from ALEX trial, we have also ALCENSA trial, which again looked at the role of, it has again demonstrated that the PFS has improved in the ALCENSA trial to 41.6 months, and also similar efficacy in the CNS metastasis. In ALCENSA, again, 5-year survival rate were 66%, similar to what we had seen in ALEX trial. And there were no further safety concerns with alectinib. It is well tolerated, with well-characterized, manageable safety profile that is maintained with a long-term use. We have a more than 5 years, or roughly around 5 years of follow-up data for this drug. So to conclude, ALEX data confirms that alectinib shows a superior PFS efficacy as opposed to crizotinib, with a median PFS of 34 months in ALEX and 40 plus months in ALCENSA trial. Longer duration of response with alectinib, suggesting that alectinib provides a prolonged response, which appears to translate into significant PFS benefit. Alectinib demonstrated impressive CNS efficacy. We know that all positive are likely to fail in brain, so it provides good efficacy even in these sanctuary sites. So various guidelines do recommend alectinib as the preferred therapy because of both improved efficacy as well as very good safety profile as a first-line option in all positive lung cancer. With this, ALCENSA, ALESIA trial, we already touched upon that. It again, in the particularly, this study was conducted in Asian patients, wherein alectinib was tested against crizotinib. Baseline characteristics were again well matched. If you see the median PFS, it improved from 11 to 41.6 months. Even among those who had brain metastasis at baseline, the PFS was 42 months as opposed to 9.2 months, suggesting very good protection even at brain. And if you look at the median OS, not yet reached in the with alectinib as opposed to 46 months with crizotinib, similar to what we had seen in the crizotinib trial with a 5-year overall survival of 63% OS rate, and as opposed to only 40% with crizotinib. And the failure rate in the cumulative incidence of CNS progression were roughly less than 15% in alectinib as opposed to 37% with crizotinib. And the safety profile, again, alectinib has shown if patient progressed upon alectinib, the chance of using the post-progression therapy, ALK inhibitor were like lorlatinib was used in roughly in 36% as opposed to 58% in the crizotinib, since there was multiple options like ceritinib, alectinib could have been used. Unlike alectinib, if somebody fails on alectinib, the later line options probably, apart from lorlatinib, very limited options in terms of ALK inhibitors. So mostly patients do go upon chemotherapy. So as we see that 11% patients were switched to lorlatinib, brigatinib 8%, crizotinib probably if they added that sensitive mutation, they were switched on to crizotinib. In crizotinib on, majority of patients were put upon either brigatinib or lorlatinib as they progressed on crizotinib. So safety profile, again, like Alex trial, it has a similar safety profile with the crizotinib. Again, Alesia trial concluded that it has a very good PFS benefit, good safety profile, and even a good efficacy in for CNS mets. So with this, I conclude my talk. Thank you for patiently listening. Now, next, if there are no questions, we'll move on to a next talk. Next, we have Dr. Srujana. She is a medical oncologist who will be discussing upon a role of EGFR inhibitors in non-small cell lung cancer.
So, good evening, everyone. Thank you, Dr. Shivshankar sir, for inviting me to have a talk on this platform. So, okay. So to begin with, today my topic is on practical management of EGFR mutant lung cancer cases in the metastatic setting, primarily. So lung cancer, according to GloboCan 2018, tops in incidence along with breast cancer with 11.6% of cases, new cases being detected every year. Whereas it also tops among the mortality cases. Around 18.4% of all cancer deaths are due to lung cancer itself. Next slide. Next. So in the metastatic setting, as Dr. Arpit has nicely given overview about all the biomarkers available in the metastatic NSCLC setting, the most important one is the EGFR mutation, which accounts for the most common mutations, most common biomarker being detected in metastatic NSCLC. So it depends, the prevalence varies between the Asian and the non-Asian populations. In the Western data, it is around 20% of patients with the metastatic NSCLC are EGFR mutation positive, whereas that figure is around 40% in the Asians. In the Indian patients, the data is approximately 20 to 25%. So what is EGFR? It is primarily a tyrosine kinase receptor, whose mutations will lead to the increased kinase activity and hence leads to abnormal cell proliferation continuously. And the most common EGFR mutations are the exon 19 and 21. Exon 19, it is deletion, and in exon 21, it is a point mutation between L858 to R. Next slide. So this subset of patients, we need not start chemotherapy at once. This is only the targeted therapy, the oral medicine. So what are the first line options available to these patients? Next slide. So across we have 3 generation TKIs, first, second, and third generation TKIs. Next slide. So we are going to go through what are the differences between each of them and with as compared to the osimertinib in particular. Next slide. So NCCN guidelines say that the third generation TKI osimertinib is the preferred category 1 recommendation for the EGFR mutant population in whom prior systemic therapy has not been started. Next slide. So coming to the first generation TKI, which are the gefitinib and erlotinib, these are reversible EGFR inhibitors, and they have got very minimal penetration to the blood-brain barrier. And the second generation TKI, afatinib and dacomitinib, they are also in contrast, these are irreversible inhibitors. This binding is irreversible. This is due to the covalent modification at the ATP binding site. And the third generation osimertinib, the advantages over the previous ones are that it has got a good blood-brain barrier penetration, and it binds specifically to the EGFR mutant receptors rather than to the EGFR wild types. Next slide. So as seen in this figure, the EGFR mutant, this is something like a lock and key mechanism. If there's EGFR mutation, either exon 19 or L858R, or the EGFR T790M mutation, the osimertinib is going to block the receptor and hence its proliferation. Whereas it has got a decreased binding capacity to the wild type GFR, which accounts for the lesser side effects of this drug, that is the rash and the diarrhea. Next slide. So the landmarks trial which led to the approval of osimertinib in the first line metastatic NSCLC EGFR mutant population is the FLORA study. In this patient, this is a randomized control trial, randomized in 1:1 ratio, where more than 18 years and the most common mutations of EGFR mutation were taken into consideration, and patients with stable CNS mets were allowed. And they were stratified according to the type of mutation as well as the race, that is the Asian and non-Asian. The patients were randomized into osimertinib and to the standard of care EGFR TKIs, that is the gefitinib or erlotinib. And once upon, if the patient progresses on the first line TKI, that is the first generation TKI, then the crossover is permitted to, the patients are allowed to receive osimertinib if the patient is found to have T790M mutation. And the primary endpoint of this trial is the progression-free survival as per the investigator assessment and according to RECIST 1.1 criteria. And the secondary endpoints are the response rates, duration of response, overall survival, and the patient-reported outcomes and the safety. Next slide. So the trial met its primary endpoint, that is a progression-free survival. The median PFS being around 19 versus 10 months. That is 9 months of PFS benefit was found with the osimertinib being used in the first line setting, and the hazard ratio is 0.46. Approximately 54% of deaths are being prevented with the use of osimertinib. Next slide, please. So the forest plot shows that all subset of patients benefited with the osimertinib, irrespective of the age, gender, race, or the presence of CNS mets, or the type of the mutation, or and whether the mutation was positive by ctDNA or anything, and smoking history, everyone benefited. Next slide. Coming to the secondary endpoint, there is the overall survival. The osimertinib had an OS benefit with 38 versus 31 months, and the hazard ratio is 0.79. So the median OS is around 3 years, more than 3 years. So osimertinib patients were more likely to be alive at the end of 3 years as compared to patients who have been receiving the first generation TKI. And this is the first time an EGFR TKI benefiting, showing an OS benefit as compared to only PFS benefit with the prior drugs. Next slide. So 28% of the patients, that is approximately 1/3 of the patients, were still receiving osimertinib at 3 years. As compared to, that means 30% of patients were receiving osimertinib at 3 years, as compared to 10% of patients being receiving the first generation TKI at the end of 3 years. That is approximately triple the benefit. Next slide, please. And the secondary other analysis, there is a time to first subsequent treatment also favored osimertinib, 25 versus 13 months. Next slide. So we know PFS is a direct measure of the drug benefit. So as we can see, the first generation TKI, gefitinib and nirlotinib, give a PFS of around 1 year, whereas the second generation TKI, afatinib and dacomitinib, give a PFS around 15 months. The osimertinib gives a PFS benefit around 19 months. Next slide, please. And the forest plots for the PFS and OS benefited all the subgroups. Next slide. So osimertinib's PFS benefit was clearly maintained across all the subgroups and irrespective of the race or the type of the mutation. And importantly, there was an OS benefit even in all the subgroups. Next slide, please. So we shall see how it fares with the first generation TKI. Next slide. When we see across all the trials which have been done in Indian patients, a retrospective or the prospective studies, whatever the PFS benefit was around 8 to 10 months in the with the first line TKIs. And the OS benefit was around approximately 1 month, except for one trial, that is the Norana et al. Trial, which took a very small number of patients, 39 patients. The OS benefit was 21 months. Next, the median PFS with EGFR TKIs in Indian patients is similar to that reported in the global studies. Next slide. So what is the data of using second generation TKI and then followed by the osimertinib? Next slide. Next slide. So even though cross-trial comparisons should not be done, but because we do not have any head-to-head trials, so when we compare the entry criteria for the Archer 1050 and the Flora, we see that dacomitinib, these patients were primarily Asian patients, and even in the Asians, the Chinese, Japanese, East Asians were the main subcategory group which has been analyzed. That is in the Flora, Asian versus non-Asian. There was no subgroups in the Asian population. All of them were taken and they were not compared in between. Next slide. And the key exclusion criteria, that's what makes the difference between the dacomitinib. There was patients who had brain or leptomeningeal mets were excluded from this study, whereas patients in the Flora, patients with CNS mets which are stable and who are not requiring steroids have been enrolled into the study, and mainly the CNS progression-free survival, that is the intracranial efficacy, has been tested for the first time. Next slide. So the primary endpoints of both the trials, the PFS, when we see initially for the Archer 1050 trial, the curve starts separating at the end of 6 months. That means for the initial 6 months, there was no more of the patients actually did not benefit for the first 6 months. But in Flora, as early as 1 month, the curve started separating. So that is why more patients have been benefited, and even at the end of 3 years also, 1/3 of the patients are being able to continue osimertinib, because that crucial period is there, because the patient's PS is going to deteriorate, and if the disease is not going to respond, the chance of the patient continuing the treatment or going to the next line treatment also minimizes. So the median PFS in the Archer 1050 trial is around 14.7 months, and the Flora trial, the PFS is around 19 months. And the hazard ratio is 0.59 in the dacomitinib and 0.46 in the Flora trial. Next slide. When we see the OS data, even dacomitinib and Flora showed an overall survival benefit, but as per the statistical hierarchical design, the overall survival was actually not statistically significant, and the p-value has not been tested, even though the median OS was 34 versus 26 months in the dacomitinib arm. Next slide. This is because as per the trial statistical hierarchical, if the trial did not show any significance in the overall response rates, the p-value for the OS also will not be tested. So that is why the Archer 1050 trial, we could not find any p-value for statistical significance. Next slide. So broadly, to compare the differences between the Archer 1050 and the FLORA, Dacomitinib was an open label study and stratification, there was multiple stratifications even in the Asian population. Osimertinib was a double blinded study, which gives a more edge towards avoiding any bias. And stratification was only Asians versus non-Asians. And more importantly, patients with CNS mets were included in the osimertinib study. And the median PFS is 14 months in dacomitinib and osimertinib 80.9 months. As we have discussed previously, the KM curve started separating early in the osimertinib arm, and the duration of response and the median OS were slightly little higher in the osimertinib arm. We will discuss more in detail about the side effects in the next slides. What is the difference between the two? Next slide. The same with the afatinib, gefitinib. Afatinib, the Lung 7 trial which showed afatinib versus gefitinib, the very few patients with stable brain mets were included. Next slide. So let's look at the brain metastasis patients. How did they fare in the FLORA? Next slide. Next slide. So the peculiarity of this EGFR mutant non-small cell lung cancers is the first generation TKIs respond very good systemically, but they fail in the brain because these drugs have a very limited brain barrier penetration. So they will be failing in the brain, and they develop CNS mets, and the quality of life is going to deteriorate. So this is where the osimertinib role comes, and it has made wonder for the metastatic NSCLC EGFR mutant population. Next slide. So the third generation EGFR TKI osimertinib has got significant blood-brain barrier penetration. Next slide. Next slide. So osimertinib has demonstrated high brain penetration as compared to the other established CNS drugs. And in FLORA, both systemic as well as intracranial efficacy were analyzed. In contrast to the erlotinib and gefitinib trials, where the intracranial efficacy was not tested for. And even in the Lux Lung 3 and 6 studies also, they showed a systemic response, and intracranial response was not tested in those trials. So osimertinib is the only EGFR TKI to report the intracranial efficacy in the CNS mets group. Next slide. Next slide. So the intracranial efficacy, as we can see, the probability of the progression-free survival is approximately not reached in the osimertinib group as compared to the standard of care, 13.9 months. Next slide. This is the same showing in patients who have known CNS mets. These patients are going to have a greater benefit with the use of osimertinib. There are less CNS progression events. The same efficacy is seen in the patients who did not have any brain mets at the baseline also. Next slide. So as per the NCCN guidelines, osimertinib is the recommended and the category 1 choice for the patients even with newly diagnosed brain mets with NSCLC as the primary tumor. Next slide. So so with any drug, there are two sides of a coin. When there is benefit, the side effects also come. So let's see what are the tolerance issues with these drugs. Next slide. The safety, the median exposure to this drug was actually doubled, approximately 20 months as compared to just 11.5 months as compared to the first and second generation TKIs, because these drugs will have the side effect of rash and diarrhea because they bind to the normal EGFR receptors also, that is the EGFR wild type, and cause these side effects, which the patients have a trouble and will be discontinuing the drugs. Next slide. So this is the same slide demonstrating how the osimertinib grade 3-4 events are far less as compared to the EGFR TKI standard of care. Next slide. So with the second generation TKI in the Lung-7 trial, afatinib versus gefitinib, around 41% of the patients have discontinued or the dose reductions were needed for afatinib as compared to the gefitinib. With the first generation TKI, it's just 1.9%. In the decomitinib arm, around 60% of the patients have had dose reductions, whereas in the FLORA trial, only 4% patients required dose reductions. Next slide. This is the same slide depicting the figures of how the tolerability of FLORA, that is the osimertinib, with the median duration of exposure and adverse events and dose reductions are quite less as compared to the comparator arm. Next slide. So exploratory analysis across decomitinib, there was higher incidence of grade 3-4 adverse, approximately 67%, and more frequent dose interruptions and more frequent discontinuations, especially in the elderly age population. Diarrhea is a difficult thing to control. Next slide. As we all know, the overall survival and the quality of life, these are the real patient reported outcomes and the endpoints for any trial. Ultimately, it is the patient who has to be benefited. So till now, we have seen the benefit in terms of progression-free survival and the overall survival for the patient. And next comes the quality of life. So the quality of life measures were limitedly studied in the Lung-7 trial. There was there was not much improvement in the quality of life in the first and second generation TKIs. Whereas in the FLORA, the global quality of life was improved from baseline in the both arms, and especially the osimertinib arm. Next slide. In fact, in the Archer 1050, then in the decomitinib, overall quality of life improved more significantly with the gefitinib as compared to the decomitinib, because the side effect profile, that is the diarrhea, is more with this drug. And whereas with the FLORA, the opposite is the true. Next slide. So why osimertinib should be given in the first line? Next slide. So if given in the first line, the median PFS is around 19 months, and then patients will be able to receive the chemotherapy, because the patient's PS, that is the performance status, is not going to deteriorate because of the side effects of the chemotherapy or anything. And in fact, because of a lot of intracranial efficacy, the likelihood of failing in the CNS is also very less. So the patient overall is well preserved to receive the next line of therapy, and hence the survival is also going to improve for these patients. Whereas the patient receives the standard of care EGFR TKI, in which the median PFS is around 10 to 12 months. Around 1/3 of the patients are going to have T790M mutation. Only those patients will be able to receive osimertinib. The other issue is in not all patients, the T790M mutation can be tested. Only because either the patient, the progression site is either inaccessible or the patient PS is poor, and in a lot of resource limited settings, testing for this mutation is also will be an issue. So and most of the patients will not be able to receive the second line of chemotherapy. That is approximately 1/3, and 1/3 of the patients will be able to receive the chemo. So which 1/3 of patients are going to develop T790M mutation? We don't know. So it's ideal to give the first line osimertinib first, so that it has got a good blood-brain barrier penetration, and it has got a good intracranial efficacy and good tolerability, and hence the patients will be able to receive chemo on progression after 2 years or 3 years. Next slide. Next slide. So this is the same slide overall depicting the synopsis of the previous slide. Next slide. So there is one study of studying the sequencing, whether giving second generation TKI first, followed by the first generation TKI, third generation TKI is going to improve the PFS, but this is a retrospective study. So sequential afatinib and osimertinib in patients with EGFR mutation. So it is an observational updated analysis. Next slide. So here the overall survival was around 41.3 months. In fact, the study showed that has commented that reserving the osimertinib for second line after failure of a TKI may result in better OS. Next slide. But to see the downsides of this study, it was primarily a retrospective observational analysis in which a lot of biases can occur. As we can see, most of the patients who are going to do bad, that is, who are T790 mutation negative and who have been not tested or who died on first line afatinib and who could not receive second line therapy were eliminated from the study. That is, all the good PS patients were taken and the good profile patients were taken into analysis for this study, which may have led to the false increase in the OS to around 41 months. And time to treatment failure is not a surrogate for the PFS. And OS was exploratory analysis. It was not a planned analysis. So GeoTac patients actually also included a lot of patients who have DEL19 mutation. So as we know, DEL19 mutations, afatinib has an edge over the other TKI, over the first generation TKIs. And it also took patients who have initiated osimertinib more than or equal to 10 months before enrollment. This also might have biased the OS to a better one. So it is not possible to draw conclusion about the relative benefits of sequential afatinib followed by osimertinib without any direct head-to-head trial comparison. Next slide. So starting with prior generation, that is the first or second generation TKI, and then treating those who develop T790M mutation with osimertinib. This is not optimal because we especially there is no biomarker to test which patients are likely to develop this mutation, and later tissue will be an issue, or liquid biopsies will be an issue, and moreover, those patients have a survival benefit if used in first line. Next slide. So osimertinib is the preferred first line treatment for NSCLC patients with common EGFR mutations, exon 19 deletion or exon 21 L858R, and especially patients with brain mets. Next slide. So osimertinib demonstrated clinically as well as statistically significant improvement in the overall survival and the PFS. So in the median OS benefit for over 3 years is now the new benchmark for osimertinib, and it provides the patients with metastatic NSCLC previously who used to survive only for 6 months to 1 year, and now those EGFR mutant populations are surviving for more than 3, and in some it may be for them 5 years also. So it is the first time EGFR TKI has translated PFS into an OS benefit, and nearly 1/3 of the patients still remain on osimertinib at the end of 3 years, and all patient subgroups showed a positive benefit in favor of osimertinib. And with additional follow-up and increased treatment exposure also, the safety profile is the same and consistent with the previously reported data. So these data confirm that osimertinib is the first-line standard of care in metastatic EGFR mutant NSCLC. Next slide. Thank you.
Thank you, Dr. Sujana, for such an excellent overview on management of advanced EGFR mutated non-small cell lung cancer. Dr. Sujana, what are your thoughts on combination with EGFR TKI, like either EGFR TKA plus chemotherapy or EGFR TKA plus bevacizumab? Do you use them? And what are your experience with them? When do you prefer to use chemotherapy plus EGFR TKA or
So
bevacizumab plus
that
EGFR
was a
TKA?
Tata-based TMH study which showed that Gefnib plus chemotherapy had in fact showed an improvement better. But I have no experience using that combination, sir.
So do you prefer, if somebody is young and not affordable, for chemotherapy plus EGFR TKA in such patients? Would you like to prefer, or you feel that is toxic, need not to add too much of toxicity to these patients like leukemia?
Yes, sir. It's the first and second generation TKIs are difficult to tolerate. Over that, chemotherapy side effects are going to add on, and the quality of life is going to deteriorate, and the patient is more likely to discontinue the therapies rather than in expecting the benefits. We might lose the patient also.
Thank you. So we have a safe drug, osimertinib. Probably that should be preferred over this combination. That's the message you want to put in. With that, we'll move on to our last session of the day, that is case-based panel discussion. I'll be moderating the session. I will be looking upon how do we manage early stage non-small cell lung cancer. What are the nitty-gritties involved in the management of early stage non-small cell lung cancer? I think my slides are visible. Do we have Bhushan sir from Max Vaishali also has joined in? Can anybody confirm?
No, sir, he hasn't joined.
That's fine. So we know that, I mean, in a metastatic setting in non-small cell lung cancer, we have an array of molecular markers and we have an array of targeted therapies and also immunotherapy. So there is a lot of change. The landscape of management of metastatic non-small cell lung cancer, if we look at 10 years back and now, it is totally changed. Similarly, we are also seeing that whatever advancements we have made in metastatic, they are slowly coming into even early stage lung cancer patients. We had seen durvalumab post CTRT. We are seeing immunotherapy in adjuvant as well as neoadjuvant setting. We are also seeing TKA. So with changes in this, we'll be looking at this case and we'll see that how things have changed in last few years. So we have a 67-year-old gentleman who is a non-smoker who presented with a mild cough, and for persistence of this cough, he underwent a chest X-ray, which showed that there is a small lesion in the left upper lobe. For that, his primary care physician advised CT chest with PET CT, which can be seen here. So we can see that there is an intensely FDG avid lesion in the apical lobe of left lung. So, Dr. Prasad, do we have Dr. Prasad?
Yes, sir. I'm online.
So, Dr. Prasad, if a similar patient walks into your OPD, how do you work up these patients?
First of all, we'll start with the detailed history, mostly focusing on the history of exposure to tobacco or occupational history. Also, would like to ask some pointers to rule out any infective etiology, considering the lesion being apical. Would like to rule out tuberculosis, obviously. So, for confirmation, we'll proceed with the tissue diagnosis, biopsy from the lesion. After various organ functions are seen, like LFT, KFT, or basic biochemical parameters are seen. So, based on the histopathology report, would proceed, sir.
So we had done a biopsy in this patient. It turned out to be adenocarcinoma. Now we have a PET CT, which has shown that it is a lesion only in apical lobe of lung and some mediastinal lymphadenopathy. And so how else? Do you have Dr. Bhushan also? So Dr. Prasad, so what else imaging test do you advise in this patient? Do you want to do MRI brain, or do you want to do any further molecular profiling on this patient?
Yes, sir. MRI brain, I would not consider if the patient is not symptomatic for any features of CNS involvement. And with the diagnosis of adenocarcinoma and mediastinal nodes in PET CT, would like to get a confirmatory test then, EBUS endoscopy, bronchoscopy and EBUS guided FNA from the mediastinal nodes for sampling.
Do you have Dr. Ismail?
Yes, I'm available.
Dr. Ismail, if a similar patient walks into your OPD, so any other further test you want to do, for example, if he is a T3N2 disease, what else you want to do? Do you advise surgery in such patients, or do you go for a radiotherapy? What do you want? What do you advise?
First and foremost, I'll get an pulmonary function test done to assess his lung capacity.
Excellent.
I will assess whether his lung functions are proper or not before intervening with radiation or going for any kind of surgery. Once the pulmonary functions are done, depending on that, I'll proceed. Either I'll suggest him for neoadjuvant chemotherapy followed by a radical radiotherapy with concurrent chemotherapy. That is a better option rather than going for a surgery in upfront N2 or N3 disease.
So you said that PFT, we all know that for surgery, we have a very well-defined criteria to whether patient can undergo surgery or not. Do you have similar PFT criteria also when you said that you do PFTs? So for radiation therapy, do you use any criteria or any cutoffs to say that whether patient is fit enough to go for concurrent chemoradiotherapy, or that patient is probably not a candidate for concurrent, he will choose sequential? Or what are the various criteria, or when do you want to go for neoadjuvant chemotherapy? Can you brief upon these areas?
Depending on the pulmonary function test, the FEV1, FEV ratio should be more than 60%. That is the basic below which we tend to avoid any kind of radiotherapy intervention upfront. We send him for neoadjuvant chemotherapy and we wait such that he will be improved. If he doesn't improve more than 60% in FEV1, FEV ratio, then we plan to get a consolidation radiotherapy rather than going upfront radical radiotherapy, because chances of radiation pneumonitis will be very high.
Okay, thank you, Dr. Ismail. Is there any role of any other modalities of therapy like SBRT if somebody has a very early stage 1? Do you consider surgery in those patients, or do you, I mean, in any particular situation you want to advocate SBRT in such scenarios?
If the patient is not suitable, I mean, not eligible for surgery at that time, especially the patient, the PET CT which I saw didn't had any mediastinal lymph node upfront I saw. These patients, if their pulmonary function test is not so good and the patient cannot be taken up for surgery, then of course we'll be able to give him SBRT and the patient will do better with that.
So what is your experience with SBRT in very early stage NSCLC? How do they tolerate?
They tolerate very well. Especially we have seen
even those with a compromised performance status, you tend to see that they do well with SBRT.
Exactly. Because the size of the lesion is very small. So the area which gets irradiated to a higher dose, that is the toxic dose, is quite low, because of which we'll be able to achieve, better tumor control when compared to advanced T3, T4 stage diseases, where the size of the lesions are quite big. There we won't be able to achieve as much as we can achieve in this SBRT cases.
So in this patient, we went upon to do, as even Dr. Ismail touched upon, that there were no mediastinal lymphadenopathy, and US also confirmed that there was no mediastinal lymph nodes. and he was medically fit. So he moved on to surgery. So final pathology report says that it is a adenocarcinoma PT2N1. Dr. Dharmishra, if the patient, if a similar patient with a probably T3N2 disease, or NVEST you would like to order, particularly with respect to biomolecular profiling or any PD-L1 marker? Do you have Dharmishra? If Dr. Dharmishra is not there, Dr. Abhinav sir, are you there?
Sir,
Yes.
Dr. Dharmishra
Sir, I'm
is
here.
on mute.
Sir, I'm here.
Oh, okay.
Sir, in this case, for this patient, I would like to go for an EGFR testing because the patient is eligible for adjuvant osimertinib. And also, since the patient is also eligible for adjuvant atezolizumab after completion of adjuvant chemotherapy, we would like to assess how much benefit the patient would get out of the adjuvant atezolizumab. We should also undergo PD-L1 testing, since the benefit is more in the patients who are PD-L1 more than 1%.
So, for example, this case comes up in a molecular in a tumor board, and surgeon says that since it is a T3N1, he wants to operate. So, do you say that I mean, should any role of neoadjuvant therapy versus adjuvant therapy? Which one do you prefer? And if you prefer neoadjuvant therapy, why do you prefer neoadjuvant therapy?
Sir, this patient has already been operated, right?
For example, if he has not yet operated, assume that he has not yet operated, and the case is put up for a multidisciplinary team review, and surgeon says that this is clearly operable, I can take it out, and followed by we'll send it for adjuvant therapy. Do you say that is there any role of neoadjuvant therapy, particularly immunotherapy? Are there any benefits to go for upfront neoadjuvant immunotherapy?
Sir, it is a T2N1 disease. It is a single lymph node involvement. It is a potentially resectable disease.
Yes,
we can consider for neoadjuvant therapy in this
so
case.
If neoadjuvant, what are the options? What do you want to go for?
Sir, since we have an option for stage 1B to 3A has been successfully recruited in the Checkmate 816 trial, where nivolumab has been combined with the doublet chemotherapy, we can give the option for that. Since there has been a specifically a very good improvement in the PathCR rates in the patients who received nivolumab plus doublet chemotherapy.
Excellent, Dr. Dharmishra. I mean, do you choose, I mean, if, for example, if he is PD-L1 negative or PD-L1 positive, does this immuno-chemo combination offer in neoadjuvant setting differ like in adjuvant setting, or do you go ahead irrespective of PD-L1 status in neoadjuvant setting?
Sir, we can go ahead irrespective of PD-L1 status in neoadjuvant setting. But I think the benefit is more in the patients who are PD-L1 more than 1%.
So some of the, as you said, some of the advantages if you go for a neoadjuvant therapy is probably that they said that in the Checkmate trial that the chances of having pneumonectomy were reduced, the type of surgery reduced. And as you said, also like number of cycles in adjuvant setting for immunotherapy, we have to go for 1 year as opposed to fewer cycles in the neoadjuvant setting.
Neoadjuvant setting.
Therapy. So that may be the advantage with a neoadjuvant therapy. And also number of R0 resection rates were increased in that trial. And also if you look at the EFS, it has improved from 20 to 31 months with neoadjuvant immunotherapy. Dr. Abhinav sir,
Yes,
for
sir.
example, this patient got operated, now he comes to you. So how do you manage this patient, sir?
After surgery, based on the histopath report, I would advise the patient for adjuvant chemotherapy.
Yes, sir.
It is, since it is PT2N1. I would prefer to give adjuvant chemotherapy. And as we know, based on the LACE meta-analysis, we have 5-year overall survival benefit of 5% with adjuvant chemotherapy. And the various chemotherapy regimens which we have at present is like we can use cisplatin, brindlebin, and since it was an adenocarcinoma, probably PEMCIS is also an option. Then for other, whether if it is a squamous cell carcinoma histology, then Paclitaxel and Paclitaxel are also options. GemCis is also an option for that. Now, further, if we know the EGFR mutation status, we can decide whether the patient will go for further after chemotherapy, whether the patient will go for osimertinib based on the ADAURA trial.
So apart from this EGFR and PDL1, do you routinely check for any other marker since we have a treatment option for EGFR and PDL1? Do you routinely check for any other molecular markers like ALK, CROS in the adjuvant setting?
At present, usually standard of care, what we are doing at our institute is EGFR mainly. EGFR and PDL1 is of course necessary. And one thing is, of course, ALK testing has been tested in many of the studies because it has been seen those tumors that are ALK positive, they have a poor response to immunotherapy. So if we are planning to use atezolizumab and suppose by chance ALK is positive, so response may be inferior.
Excellent point. And even in the metastatic setting, we are seeing that if somebody is onco-addicted tumors, they tend to not do well. So probably the data in these subgroups is very limited with respect to immunotherapy. So probably if somebody is EGFR or ALK positive, one may avoid using this immunotherapy. And also for EGFR, we have a adjuvant setting osimertinib, as Dr. Sujana has very nicely presented in the previous talk. And also there are upcoming studies, there are ongoing studies as well in the other settings like ALK setting to look for the role of alectinib. If some trial access is available, if they turn out to be positive, those patients can be recruited in the trial as well. Do we still have Dr. Ismail?
Yes, I'm still available.
Dr. Ismail, how often do you see that early lung cancer patients like stage 1 to stage 3A, how often do you see that they undergo surgery as opposed to radiotherapy?
It depends on the nodal stage predominantly.
In your practice?
We predominantly get locally advanced stage 3 diseases who are like not unresectable and probably are planned for immunotherapy after concurrent chemoradiotherapy on loan. Very rarely we get few cases who are the patient are not eligible for surgery. In our institute,
in our institution or in Indian scenario, so we tend to see more of like 3B and onwards disease.
Exactly.
If stage 1 to 3A, majority do undergo surgery. If they are unfit for surgery, they will be put on radiation therapy.
Exactly.
So, for example, if this patient had undergone surgery and if he comes for a margin positive, is there any role for surgery or adjuvant radiation like PORT, or when do you choose PORT?
After lung ERT study, the role of adjuvant therapy has become, adjuvant radiotherapy has become very minimal. I agree with positive margin. We can go ahead with radiation in cases of highly aggressive tumors, like high-grade diseases. But other than that, in adjuvant settings per se, we don't have any role of radiotherapy. We'll proceed with chemotherapy adjuvant.
So already we have, thank you, Dr. Ismail. We touched upon the role of neoadjuvant therapy, particularly in case of surgery, we do incorporate neoadjuvant immunotherapy because of the kind of surgery they undergo following the neoadjuvant therapy is less pneumonectomies were done in the trial. And also, if you look at the number of cycles of immunotherapy as opposed to adjuvant, it is 3 cycles as opposed to 1 year. So cost reduction. And also we get a biology of disease. If somebody achieves a PathCR, like in breast cancer, they tend to do better. So we get this information as well. And if they do not achieve PathCR, probably in the later, in the years to come, we may see how to escalate therapy in such patients as well. And Dr. Ismail also has touched upon probably if somebody's radiation portal is big enough, they cannot encompass in a single field, probably those patients you do tend to refer for neoadjuvant therapy. So moving on to our patient. So he had a PT2N1 disease and it came out to be EGFR mutated and L858R. So, and also his PDL1 is 40%. So, Dr. Dharmishta, so how do you go ahead with this case? Dr. Dharmishta, probably you are mute. Dr. Dharmishta, are you around?
So Dr. Dharmishta
Yes, sir.
is on mute.
Yes, sir. Yes, sir, I'm around. So there is a network problem actually, sir.
So I'll repeat the question. This patient finally turned out, we did a molecular panel on this. He turned out to be EGFR mutated, L858R, and PDL1 is 40%. And he had completed his adjuvant chemotherapy.
Sir, in this case, I would like to discuss with patient the role of adjuvant osimertinib, since he is EGFR mutant. In this case, he is by stage, he is fitting into the criteria when we can put the patient on adjuvant osimertinib. So that I would like to discuss with the patient.
Okay. And what kind of chemotherapy do you consider in adjuvant setting?
Sir, in adjuvant setting, since it is adenocarcinoma, we can go for platinum-based, cisplatin-based chemotherapy, a doublet, cisplatin-based doublet we can consider for this patient.
So, I mean, what are the benefits if patient wants to know that what is the benefit he will derive from chemotherapy? So, how do you counsel such patients?
Sir, I will have to read further into it to be able to counsel this patient actually.
So, we have for that LACE meta-analysis, as we can see on this screen, that as the stage increases, we usually give adjuvant therapy if its size is more than 4 centimeters. As we see that beat any cancer, as the stage advances, the incremental benefit increases. In stage 3, it is roughly around 13%. So you touched upon adjuvant osimertinib as well. So this is the Kaplan-Meier curve, which is showing a huge PFS benefit. So, but we do not have a OS benefit. So what are your thoughts? Does it change your practice to give adjuvant osimertinib? Dr. Abhinav Diwan.
Earlier, like it was a trend towards seeing like we used to consider the primary endpoint as OS. But I feel for a disease like lung cancer, which is an aggressive disease, probably we have to stop thinking in terms of OS and probably think about DFS. And based on this DFS, probably I would like to give adjuvant osimertinib. And if we look at the hazard ratio, it has got an excellent hazard ratio of 0.17 for stage 2 and 3A, and for overall population also it is just 0.20. Probably if given an option, I would consider the patient for adjuvant osimertinib also.
We also have so many trials in adjuvant setting with other EGFR TKI which have failed. So do you think that one trial with ADAURA, though I mean the results are very impressive, what do you think that makes a difference with ADAURA as compared to other trials which have failed in EGFR TKI? Is it something to do with the irreversibility? Is it something to do with CNS penetration?
One of the reasons maybe one is of course CNS penetration. Other trials that have actually tested adjuvant TKIs were using basically Geftinib or erlotinib trial that are first line TKIs, first generation TKIs, and that are known to be based on the metastatic disease, are known to be inferior to the osimertinib. Probably osimertinib, though if you look at those studies, that is the RADIANT study or SELECT study and the adjuvant study, the hazard ratio was 0.6, and we know osimertinib works better. And if we look at the hazard ratio in this case, it is 0.7 to 0.20 in this ADAURA trial. And of course, osimertinib works much better in comparison to the first generation TKIs. Also, it has much more better CNS penetration. Often we come across a situation like if it is early stage lung cancer, we tend to not do MRI brain also, which is kind of a gray area because NCCN says for 1B, it is optional. For stage 2 and 3, it should be done. But the thing is, for early stage cancer, if we don't do MRI, we may actually miss the brain mets. However, that can be compensated or taken care of by osimertinib. That works well for small CNS mets also.
Excellent, sir. I agree that even if you look at the breast cancer also, apart from trastuzumab and olaparib, hardly we have any other drugs which have shown OS benefit, but we have incorporated many drugs into the management, be it TDM1, be it pertuzumab, all were incorporated based on the PFS benefit. Given the magnitude of benefit and also probably some of the theories as you highlighted, that is irreversible nature of this osimertinib as opposed to reversible nature of first generation TK, and also some of the common sites of failure with EGFR mutated is brain, where osimertinib provides a protection. So probably these are the factors which may has resulted in a huge translation in benefit. So we need not have to delay providing this benefit, saying that wait for OS benefit. We should always, if it's not an issue, definitely patients should be considered with such a benefit for adjuvant osimertinib. Point well taken. So we already touched upon this. So EGFR mutation, the sites of failure. If you look at in the osimertinib, only 1% failed in the CNS as opposed to 10% with the placebo group. And also, if you look at the CNS, is a common site of distance recurrence among patients with EGFR mutated receiving EGFR TK. In the adjuvant RADIANT study, 37% of the recurrence in patients with EGFR mutated were in the CNS involvement, where gefitinib or erlotinib, such kind of first generation TK, hardly offer any protection. So we touched upon this. Dr. Abhinav Diwan sir has agreed that it is practice changing. Dr. Dharmishta and Dr. Prasad, what are your thoughts? Do you think that it is practice changing ADAURA, or do you want to wait for OS benefit?
So seeing the PFS benefit that it gives and the protection from development of further CNS metastasis that it gives as opposed to placebo as seen in this trial, I do definitely feel that ADAURA is a practice changing, and the option of giving osimertinib to these patients should definitely be discussed in with a proper discussion of the pros and cons. The patient should have the option to choose between taking osimertinib in the adjuvant setting as opposed to taking chemotherapy.
So you agree that OS, waiting for OS, we need not have to wait for OS, and it should not be much of concern. That's what you want to suggest?
Definitely, sir, because once the disease progresses, if it is a metastatic disease in NSCLC, we do know that we have a myriad of options that we can give to the patient once it is in metastatic setting too. But the kind of PFS benefit that ADAURA is offering, I do agree with Dr. Abhinav Diwan that we should take into consideration that, and we should go ahead with giving it to our patients.
So, for example, if this patient receives osimertinib 2 years down the line, he fails and he becomes metastatic. So, what options do you want to give? ABCP, and he had a PDL1 40%.
Probably, sir. Once the patient progresses, then we have to, as we know the protocol, we would like to biopsy the patient. We would like to see what kind of other mutations are there in picture, because we have so many myriad of targeted therapy options available for the patient.
Okay.
And then we should take the option of adding immunotherapy.
Okay, good. Only I think atezolizumab, apart from atezolizumab, not any other drugs are tested, I think, in EGFR mutated, the 2 ABCP regimen. Dr. Prasad, what are your thoughts? Do we have Dr. Bhushan, sir?
Hi, hello. Yes.
Hello, sir. Good evening,
yeah,
sir.
Good evening, good evening.
Sir, we missed you early. Sir, if stage 3 lung cancer clinically at T3N2, if he walks into your clinic, so how do you differ that whether patient should go for radiation therapy or surgery? Do you advocate him routinely radiation therapy, or do you advocate surgery? How do you choose such patients, sir? And also, the second question
First of all,
a second question is, how do you determine clinical fitness for any patient for choosing therapy? What are the factors what does type of surgery determine whether patient should go for surgery, or whether any clinical parameters dictate whether patient should go for surgery?
Okay, whenever I see a stage 3A patient, basically N2 disease,
Yes, sir.
I look it as a microscopic disease more in cancer patients.
Okay.
So first of all, I will see whether it is whether there is any role of operation or not and resectability. So probably N2 in my definition doesn't come under resectability situation, although all guidelines might be presenting like N2 discrete single node can be excised, single station, this thing. Okay. So one thing is operability. Operability determines the how the patient is going to present clinically fit or not fit. The fitness has to be evaluated by pulmonary function test and dobutamine cardiac function test. Basically, dobutamine stress echo. The PFTs should be around 40 to 45% for a lobectomy. Minimum, bare minimum, and almost 30% for pneumonectomy. Nowadays, we defer pneumonectomies because with the advent of chemoimmunotherapies, we have started reducing the number of, it is lung conserving surgeries have come into picture.
So that's a great point.
Stage 3A
So-
N2 disease. First of all, I will confirm the N2 disease by EBUS assessment.
So what set of patients do you refer for neoadjuvant therapy like IO plus chemo, or what set of patients you would like to operate upfront, sir?
Patients with N1 status of lymph node, N2 negative,
Yes, sir.
or single station N2 and non-central or peripheral disease, squamous cell carcinomas, good performance status. These will be coming into operable setting.
Okay.
But with advent of chemoimmunotherapy, there is something called incidental N2 disease.
Yes, sir.
Yeah, so that's what all we surgeons and physicians, everybody fear about this. You operate this patient and the histopathologist tells that he has got multi-station N2 disease.
Yes.
So why this problem is occurring? Across the country, you see there is no single solid guidelines for pulmonologists to do EBUS, and EBUS is a subjective procedure so we don't know which patient where it is 100% N2 negative or N2 positive, or there is N3 also present.
Yes, sir.
That is a practical problem in India we face.
So what set of patients do you refer for any patients for neoadjuvant therapy, sir? Neoadjuvant immunochemo?
Yes, definitely. All patients, my patients with central disease, N2 node, or if at all stage 3A, nowadays I counsel them for chemoimmunotherapy because that gives me path-CR and the survival advantage I get in these patients.
So if somebody receives a neoadjuvant immunochemotherapy, do you think, sir, does it changes any of our complications with surgery?
Yeah, definitely. Yes, the surgeries have become little bit difficult with neoadjuvant chemo. Initially with chemotherapy, where okay, the level of expertise was moderate, but with immunotherapy coming into picture, the level of expertise as a surgeon has become very high. The nodes are stuck to the pulmonary arteries. The nodes are embedded into pulmonary arteries. There is a lot of dense fibrosis, especially if you have a central base located lesion or a positive N2 disease, where it becomes really very difficult for you to resect these nodes. But with time, the expertise is coming on slowly. We are able to do safely minimal invasive lobectomies in these patients also. So I don't think so it would be a major challenge for as a surgeon to do all these difficult procedures.
Sir, another question in the CheckMate trial, if you see that those patient who had underwent received a neoadjuvant chemoimmunotherapy, they went on to, the number of the number of pneumonectomy rates were reduced.
Yes.
So how does the type of surgery, is it defined upfront, or does it change based upon the response to neoadjuvant therapy?
Yeah, I will tell you with an example. Last 3 months, we were treating one patient, 66 lady, with a right lower lobe mass, which was extending into the interlobar PA and also was touching the right upper lobe PA and also well as the bronchus. So, and EBUS confirmed N1 node.
Yes,
Okay, the size of the lesion was 5 centimeter to start with. Okay, so this patient, if I would have operated upfront, 100% this patient would have required pneumonectomy. And therefore, the morbidity of the pneumonectomy, it's like cutting somebody's one leg. It's like amputating somebody's one leg. So we subjected her for the checkmate trial, the nivolumab, and as well as the platinum-based chemotherapy. The chemo-immuno combination, 3 doses of nivolumab were given. And after 3 doses of chemoimmunotherapy, we did a check PET CT. PET CT, we found out that a 5 centimeter lesion had almost disappeared. Only the interlobar node, which was the N1 node, it had showed PET avidity.
Okay.
Now the crux was whether to do EBUS or not do EBUS in this patient and to prove it or not. But in our case, the patient and the family were hailing from London. They said, you remove it. So we went in with robotic surgery. We had a very difficult time dissecting the fissures and separating out the nodes. This was our consecutive 5th or 6th immunotherapy surgery. We had to open this case, literally, to prevent any further accident. And even with the open surgery, it was very difficult to separate the node out. But finally, we could separate the node out. And after 10 days, the pathology report came, complete path CR.
Excellent, sir.
And
So
nodes were reactive nodes.
So with this case scenario, sir wants to add in a point probably that if this patient underwent a upfront pneumonectomy, hardly he would have been fit enough to receive any adjuvant modality of therapy. Since she was offered a neoadjuvant therapy, even the having pneumonectomy also reduced. If a patient requires any adjuvant therapy, still he can receive adjuvant therapy safely, and his overall quality of life has also improved. So this is another point which advocates towards more of neoadjuvant, particularly in these settings, rather than upfront surgery. Is that what you want to suggest, sir?
Yes, 100%.
I think with that, we have come towards the end of our session. We had a very valuable input from all our faculty. Thank you all for joining in and pitching in your points. With that, I conclude my talk. Thank you. Thank you, sir.
Thank you, sir.
So now we are at the end of our session. We had a very good sessions regarding management of metastatic non-small cell lung cancer, as well as we touched upon with case-based discussion on early stage lung cancer. So this concludes our today's discussion on lung cancer, recent changes in lung cancer. Thank you everyone for your valuable time to join this program. And at the end also, I'd like to thank AstraZeneca, Roche, and Intas for providing this wonderful opportunity to having this CME. Thank you.
Thank you everyone for joining.
Thank you.
And thank you to our academic partners. Good night, everyone. Thank you, Yashika. Thank you, Nishant. Thank you, support team.